I want to formally welcome us to the December 2024 meeting of our association, the Guild. We are starting a week earlier than we would ordinarily have done because the 26th is Boxing Day and we didn't want to interrupt anybody's Christmas celebrations. So that's why we're having our meeting today. And I would like to tell you that we're in for a good time. So I'll hand over to Dr. Balaji Lawal to say one or two words before we introduce our speaker for today. Over to you, sir.
Okay, thank you very much, Dr. Eletu. I have great pleasure in welcoming all the distinguished people who have joined us so far in the hope that more people will join for this very, very exciting session. I welcome in particular guest presenter, Dr. Yewande Oshodi, and thank her very much for joining us. Today's topic is very, very fascinating and also very necessary for all pediatricians. I hope more pediatricians will join because mental health disorders in children can be tricky because children typically depend on their caregivers and the the health workers who look after them, the doctors and so on, to identify these problems. Unlike physical ailments where the child may complain and say, well, I have abdominal pain, I have this, I have that, I have sore throat, and it's even more difficult during adolescent years when a lot of changes are taking place and you don't know which one to attribute to normal changes in growth pattern or development pattern, and you don't know when it's outside normal range. So it's very, very important for caregivers and doctors who look after children to be aware of the early signs and how to spot these things in order to be able to help these children very early. So it is in that vein that I am excited about today's meeting, and I look forward to learning, just like I believe everybody else on the platform. So before I hand over to the presenter, let me wish everyone here compliments of the season and have an enjoyable holiday season after this. Back to Dr. Elitu. Thank you very much.
Thank you very much, sir. So Dr. Ireti Fajolu is our moderator for today. So I'll hand over to her to take over and introduce the speaker. Ireti, over to you.
Thank you very much, Dr. Eletu. Good afternoon, everybody. I'm not sure I can really identify everyone who is on the call, but I want to say a very good afternoon to you and compliments of the season to everyone. And thank you for joining this seminar today. And I must appreciate Dr. Eletu and Dr. Balaji Lawal for setting this up and how far we've gone over the last, I think, this is the second year running or so. So thank you very much. So my call today is to moderate this session, and I'll be introducing our speaker for today, a dear sister of mine, Dr. Yewande Oshodi, MBBS, MPH, FMC, Psychiatry, MPhil, Certificate in Child Health and at Child and Adolescent Psychiatry. Dr. Oshodi is an associate professor of psychiatry at the College of Medicine of the University of Lagos. She's also a consultant psychiatrist at the Lagos University Teaching Hospital in Lagos, Nigeria. She has over 25 years experience as a medical doctor and had her undergraduate education at the College of Medicine of the University of Lagos, which is also my alma mater. A specialist and subspecialist qualifications were obtained from the National Postgraduate Medical College, Faculty of Psychiatry, and the Colleges of Medicine of South Africa, respectively. Dr. Oshodi holds a Master's of Public Health from the University of Lagos, Nigeria, and also a Master of Philosophy from the Stellenbosch University, Cape Town, South Africa. She has over 40 peer-reviewed research publications with emphasis on public mental health, child and adolescent psychiatry, along with women and infants' mental health. She has also served in various leadership and senior hospital management capacity, and she was the immediate past deputy CMAC of the Lagos University Teaching Hospital. Dr. Shudi is a public speaker, and I'm sure you would agree with me on that when she starts talking to us. She's also a minister in the Covenant Nation Church, a marriage counselor, and she enjoys mentoring younger colleagues and women in particular. And I'm sure she will enjoy mentoring us, even though some of us are not her younger colleagues, but I'm sure we're going to enjoy this session. Over to you, Yewande. Thank you very much for coming on today.
Thank you very much. Thank you. Thank you so much, Dr. Fajoli, for that kind introduction. I want to thank Dr. Mobolaji Lawal again. Thank you for organizing this, and Dr. Eletu for all the efforts in making sure that we kept to time and everything was ready in time for this meeting. I want to say a very warm good day to everyone on the call, both colleagues and I suspect a lot of senior colleagues. Thank you very much for having me. I've been introduced and I'm going to spend the next pretty much about 40-45 minutes trying to give you a bit of an overview about child and adolescent mental health issues that may be of concern to you as pediatricians. I'd want to quickly make a disclaimer that I don't think this is going to be exhaustive by any means, but it's just to stimulate your interest or generate further interest and maybe further capacity on how you're going to think around child and adolescent mental health issues already. Fortunately, I have been able to relate with quite a few pediatricians, Dr. Fajolu, Professor Leshi, quite a few in my teaching hospital, and we've had a very good relationship in co-managing cases or situations. So I'm hoping this would be worth your while. I work in the College of Medicine and the Lagos University Teaching Hospital, as I've been introduced. And I would want to just start by reminding us that, when we think about the definition of health, according to the World Health Organization, you do recall that, mental health and social well-being is also very intricate to that definition. And because of that, pediatricians also play a very important role in ensuring that children and adolescents who are not excluded from having mental health concerns, by the way, are catered for. And this is because most of your patients would rather see you when they have behavioral problems or overt mental health problems before they come to see someone like me. So this is the stance of the American Academy of Pediatrics, where I found this statement, and I suspect that the Guild of Pediatricians in Lagos, that this team represents, also feels the same way, and that's why we're talking about this. Your role is important because you are really the first resource. You are an important first resource. They may try other places, but most people that have a pediatrician will probably be relying on you to provide the right guidance to them when and if they are struggling with mental health issues. So when we say mental health, we're talking about, sorry, my slide just skipped beyond itself. We're talking about conditions, feelings, thoughts, and behaviors that are as such that are beginning to affect the individual's capacity to cope. And this can be experienced by children and adolescents worldwide. They're not excluded. And according to the World Health Organization, you can be sure that between 1/10, to about 20% of children and adolescents will experience mental health problems. And these are not necessarily because they're in the clinics or because they're psychiatric patients. Just survey any group of children, about 10 to 20% of them will have an experience of a mental health problem. And it goes further WHO goes further to highlight to us that mental health disorders are contributing significantly to disability amongst children and adolescents. And indeed, it's ranking very high amongst, the presence of these disorders is ranking very high amongst this population group. It's a huge public health concern. It's causing disability, affecting them functioning academically and socially as they should. I want this to sink in because what we have is a potentially hidden burden, if not addressed holistically by you and I. Your role in finding out how your patients are doing with regards to their mental health is not just a thing that is a fancy thing. It is about providing comprehensive health care for them because they may not get it anywhere else. To further highlight, the burden of mental health problems in adolescents, so you can see the Eko Akete logo on this slide. I used this slide when I presented at the Pediatrics conference early this year. Apologies, I forgot to take it off. But it's just to further let you see that half of all mental health conditions will start before the age of 14. So any person you see with a mental health problem, half of them, their problem started before the age of 14 years. And 75% of all mental health problems will have been established by the time they're 24 years of age. So you see that the population that you are caring for are really at the zone, the high risk zone. That is when they're coming down with their first mental health challenges or their first diagnosed mental health condition, and they're vulnerable. Just being an adolescent itself, I like what Doctor said at the beginning, Dr. Mobalaji Lawal, that adolescence is a period where so much is going on. That period does not insulate them from mental health problems either. Being an adolescent indeed puts them at further risk of mental health problems because of the way their brain is configured. It's wired at that point in time where you have the executive function still lagging behind the reward systems, the reward portion of the brain. So all of this underscores that there is a huge burden. Suicide is the fourth leading cause of death in 15 to 29-year-olds. So a 15, 16, 17-year-old is probably seeing a pediatrician somewhere, for whatever health concerns they have. And if their depression, anxiety, behavioral disorders can be detected, then we'll be making a whole lot of difference for them. I'll go back to this slide to say where I highlighted, just to emphasize the fact that when we fail to detect this or support them, the mental health conditions will extend into adulthood. And it will then go on to begin to impair their physical well-being and their longer-term mental health, and limiting the opportunities of employment, and poverty becomes, a thing in lives of children that maybe, didn't get the help they needed when they were struggling. This is really just to help us see a bit of the burden in Nigeria. We have over 30 million Nigerians aged between 10 to 19 years. That's a lot of people. And nearly a third of Nigeria's population, I'm preaching to the converted, right? But I think I want you to look at it in the context of the information now that these people who are such an important and huge population are at extreme risk, of coming down with these illnesses at this stage of their lives, et cetera, et cetera. And despite varying prevalence rates, studies conducted in several parts of the country have shown that conditions like depression is extremely common, and adolescents suffer a lot from it. In 2010, in a secondary schools were surveyed, about 400 students, and we found that there are, behaviors that are supporting, that are going to put them at risk going on. Substance abuse has been with us for ages, and it's, if anything at all, increasing. As at 2010, we had lots of alcohol abuse, tobacco, cannabis going on among secondary school students who may end up being patients of a pediatrician, you know, and they give different reasons for doing this. Another study by Professor Anyimode in 2012 in a primary care center showed us that 11.4% of children, just regular children coming for follow-up, had a diagnosable psychiatric disorder. And of course, some of them were functionally impaired and was impacting them in other ways. So this is a more recent study also confirms about 10% of adolescents in Nigeria are suffering from mental health disorder, and this prevalence is increasing. I just thought it would help for us to look at these figures. You know, we're seeing another study about 15%, you know, in a pediatric population, you know, a study we did in 2013 amongst healthcare providers, of which the pediatricians were about 62.4%. Most of them confirmed that they felt a little bit incompetent regarding child and adolescent mental health issues, and confirmed that training was necessary and were willing to get trained. I say that to make the point that beyond the pediatricians in this room, your experience, you've been doing this for years, I think that piece in, you know, the training generally being emphasized, I think would really help us as we go along. There are certain barriers in our environment that makes this conversation very important. They face limitations around access. People are paying out of pocket. You know that even for regular healthcare, they're paying out of pocket. So when they don't have enough resources, it's the mental health that suffers. They'll say, we'll take care of that later, or we can't afford it. Or they're located where there is no mental health expert, or there's no political will to set up, you know, a service near people where they can access their mental health care. The other thing is in training, very few trainees want to do psychiatry. It's not as lucrative as maybe others. Maybe pediatricians are richer than us, you know. That's why they don't want to come and do psychiatry, or obstetricians and gynecologists. You know, Christmas is around the corner. People get hampers. We hardly get hampers, I promise you, because, you know, no one wants to really say, oh, I have a psychiatrist I'm going to give hampers to. So trainees are not coming. The interest is limited. And even when we do have people go through psychiatry, very few people subspecialize in child and adolescent psychiatry. I'm making a case to let you see that we are relying on you to help these children attend to their mental health and address their mental health challenges. There's a lot of stigma and cultural beliefs around mental health disorders. I must admit that in the last, say, since COVID, that has improved a lot because there's a lot more public talk about mental health problems. But don't forget that children are relying on their parents to allow them access to treatment that they need. So if their parents have these biases, they would not readily allow their children get the care. And I see that all the time. A child is, you know, referred to me from a school, and the parent sits on it and says, no, we don't need a psychiatrist, we'd rather go elsewhere, because of their beliefs, because of what they suspect they're going to experience. Felt or courtesy stigma is really a thing where people feel if I go to see a psychiatrist, it means that my family is doomed. We have insufficient personnel, inadequate funding, and the list goes on. These are barriers that are present in accessing mental health care for children and adolescents. So you have a very important role, pediatricians, in addressing the mental health care needs of children and adolescents. One important role, as you can already guess, is in helping to bridge the gap, what we call the treatment gap. What is a treatment gap? The treatment gap is the gap that is seen between those that require treatment and those that actually get it. And it is said that there's a huge treatment gap for psychiatric problems generally. So if general psychiatric problems have huge treatment gap, child psychiatry is like the ugly stepsister of psychiatry that is even neglected. Children should be heard, not seen. So we need your help to bridge that gap. We need you to build capacity. We need you to be acutely aware, to be thinking about mental health when you're thinking about health. We need you to also realize that for the well-being of your patients, you may need to conduct routine mental health screenings. Remember, this is an overview. I'm not trying to make you psychiatrists. I'm trying to just gently shift your approach a bit to be able to accommodate a bit more of child and adolescent mental health when you think about your patients. We expect you to also provide education and support to families. So you want to refer a patient to me. When they hear from you that this is important, your child needs a psychiatrist, it's part of the treatment, you have definitely helped them move a bit further from where they would have moved on their own, just feeling, oh, psychiatry, oh my God, how on earth did we get here? No, I'm not going to go. It's important to also collaborate a bit more between pediatricians and the mental health professionals so that we can think around cases, we can think around planning services, we can think around follow-up care together. So I do have patients that at times I have pediatricians, I'm on the call regarding a patient that we're co-managing. This is what's going on. What do you think? Oh, I'm going to need to do this to this medication that you've placed the patient on. Can we think of an alternative? And a bit of back and forth like that. And at the end of it, the person that benefits is the patient. And of course, also advocate for policies and programs that will promote the mental health well-being of your patients. And all these reasons are also, highlighted in the images by the side. Psychiatry and pediatrics do have an intersection around certain cases, apart from just general mental health and well-being of your patient. At times, there are cases that will result in an intersection that we need to take a look together. It's a crucial area of study, this intersection, because it's recognizing the intricate relationship between the physical and the mental health of children and adolescents. And we must never forget that there is an intricate relationship between. And at times, the physical health is screaming aloud that, look at me, I'm here, I'm running a fever, there's an infection, I have a headache, I have aches and pains. You must always think, what is the mental health implication of this experience in that child that you are taking care of, that urgent, those urgent physical symptoms in that. I apologize for this busy slide. It's my attempt to try and reduce my number of slides, but let's just run through it, okay? This intersection will require, that in both fields, we're thinking very developmentally about psychopathology. We need to understand that there are certain disorders that develop at certain points in time in children and adolescents and how they can impact their physical health and development. For example, you have adolescents that are receiving treatment from you. What does an adolescent require when they're psychologically at that age? That is thinking developmentally. They require that they're able to be an individual. They're able to take on responsibility. They can be independent. They're relying a lot on what their peers say. And recognizing that, you can essentially utilize that to your advantage by providing that support for them where they're freed to express that psychological need of being independent, of not being told what to do. Of course, you're going to tell them what to do, but you can then manage them a bit more intentionally with that in mind, without necessarily thinking, oh, they're being difficult. It is what an adolescent is expected to do developmentally. They are pushing for independence. They are going to be pushing against control. And we need to then guide them in a safe way to be able to achieve that, that need versus, the healthcare you're providing for them. For example, you can allow them to monitor their medication to some extent. Little things like that is supporting their mental health needs. And at times, parents don't know. They're treating an adolescent the same way they'll have treated a 5-year-old. And they're then having conflict. Your knowledge about this can definitely turn things around very quickly. Pediatric psychopharm. At times, we will need to place some children or adolescents on medication, and your knowledge about the medication and thinking around with the mental health practitioner about these meds and the potential side effects, will definitely be helpful. There are certain medications. I'm sorry, I need to. There are definitely certain medications that may have reactions and interaction with other medications. Excuse me.
I think you should have a glass of water.
Yes, yes. I think it's just the dryness. Okay, apologies for that. The other thing is when we're taking care of children and adolescents with psychiatric problems in medical setting, we may need to think about helping them access care in that setting. Liaising with the psychiatric team to provide the care in a timely manner or ensure that the referrals are well done. At times, in emergency departments, patients show up. Once they have behavioral things, sent to psychiatry. But we need to screen out other things before you send to psychiatry. We need to be sure that there's no medical comorbidity responsible for this before you send to psychiatry. It's not every behavioral problem that is purely a psychiatric problem. Yes, they may have behavioral issues that psych must come in to support and rule out and calm things down. So we must collaborate. We must collaborate. Even when your regular patient is referred out, it helps to also check in. How are they doing their meds? Are they compliant? And all of that. Neurodevelopmental disorders, things like autism, ADHD, at times they're being diagnosed by the pediatrician or the child psychiatrist, and either it's fine, or we need to also realize where you need a bit more input from one team or the other. These are intersections that we cannot avoid, and neglecting to pay attention to them makes only one person suffer, and that is the patient. Trauma and stress. The role of trauma and stress is often unseen. At times it's overt, clearly it's seen. At times it's unseen. It may be as simple as parents fighting at home, and we're then having behavioral consequences as a result of it. I remember a few years ago, a child was referred to me. This child, I think, kept vomiting or something, had a GI symptom that was, the pediatricians couldn't resolve it. And eventually we discovered that the parents were about to have a divorce. And the child had to remain ill just to keep mom and dad together. As simple as that. As long as I remained ill, my parents will stay together. And that's the kind of dynamic that at times, if we are not aware of what's going on and x-raying it, could there be a stressor in the life of this child that could contribute to what we are seeing, or to the flare up, or to the complications that you are having in your otherwise straightforward pediatric patient? It may well be a mental health issue that needs attention. Cultural competence, I think that cannot be overemphasized. The setting in which we're practicing, we need to be mindful of it, even though we're living in an increasingly globalized world where everybody is almost seeing what everybody is doing. But there are things that are a bit unique to our environment, and we need to be sensitive about that and how that affects several things, about how we're managing the case. And of course, research. I'm going to try and move a bit faster now. So I'm going to take a look at, just run through a list of some common mental health issues in children and adolescents, and highlight a few things we should take a look at. I have a case scenario. I named her Chichi. Absolutely, it's not a real patient. That's what I'm trying to say. So it's a case scenario, but I think I've tried to put all the pieces. I had two, but I'm going to just work with this one because of time. The other was a younger child, and I hope this helps us have a sense. Chichi is 14. She came to the clinic with complaints of fatigue, trouble sleeping, difficulty concentrating. Over 2 months, mom noticed significant change in her behavior. She had become irritable, withdrawn, disinterested in activities she once enjoyed, such as playing soccer, hanging out with friends. Remember, she has fatigue, trouble sleeping. These are things that a clinician, a pediatrician will be wondering, why is this child tired? Chichi, who previously had excellent grades, has been struggling in school. Her mother is concerned about her academic performance. Initial visit, she reported feeling tired all the time. She then reported feeling empty or sad. She doesn't really know why. She says life at home is calm, but she's been feeling overwhelmed and unmotivated recently. She denies any major stressors in her life. Although her mother notes that when they went through a difficult divorce, the transition seemed to have challenged Chichi. Now, that may be an insightful mother that can volunteer that. Some other parents will keep mute on it. You may need to probe. And don't forget, the parent may not know what you're looking for. But once you have a high index of suspicion that could there be some psychosocial stressor in the life of this child, we should look at. The pediatrician initially thought the symptoms were due to normal adolescent stress, particularly due to family changes, and prescribed some strategies for stress and sleep hygiene. And I think that pediatrician is you know, a psychologically aware one to have even done this already, you know. But the point really is we're trying to see what we can do to help. Then advise mom to ensure she stays physically active and encourage her to talk openly about emotional challenges she may be facing. During follow-up visits later, mom reports that Chichi's symptoms have worsened. She now refuses to participate in any activities. She's withdrawn further. She's avoided school entirely. She's lost weight, began to mention hopelessness, but denies suicidal thoughts. At this point, the pediatrician is considering depression as a possible diagnosis. So further questioning, she's feeling worthless, having thoughts of maybe not being around anymore. You know, she never said she wanted to kill herself. So at times they may not say they want to kill themselves, but they start saying things like, no one's going to miss me, no one really cares. And that may be suggestive of thoughts of, well, I may as well not be around any longer. She denies any plan on intent, but she reports she feels like a burden and struggles to find joy in what she is doing or what she used to enjoy doing before now. So Chichi's case essentially highlights the importance of considering depression in adolescents, even when, you know, the symptoms are not, you know, as overt, oh, this is depression, you know, and early recognition and treatments can definitely prevent more complications. In Chichi's case, you can see that even the diagnosis was delayed a bit, and that may have worsened, allowed the symptoms to get worse, and God forbid, she may have even acted on her suicidal ideation, you know, before coming around the second time. So I just thought that was a useful one. If we have time, maybe we can look at the second case scenario, but I just wanted to do that. So as pediatricians, you need to begin to also become very mindful of risk factors in patients that may put them at risk of mental health issues. Things like a family history of a mental health disorder, trauma or abuse, chronic illness or disability, a child living with anything from sickle cell disease to cancer to nephrotic syndrome. These are chronic illnesses. This makes them, you know, almost entitled to having a mental health challenge somewhere down the line. And just being aware of that and being ready and identifying the resources that you're going to connect them with when they're struggling can make all the difference. Patients with social or economic disadvantage, patients who have experienced bullying or peer rejection. Don't forget that the patients will never come and say, oh, I'm experiencing bullying all the time. You probably may just discover it by asking, tell me, how is school? How are your friends? You know, as part of the history, being psychologically aware, like I said. Adverse childhood experiences is a concept that describes children that experience before age 18 certain things that put them at risk of physical and mental health problems later on in life. It includes things like a dysfunctional home, parents divorcing, you know, abuse, a mentally ill relative, an incarcerated family member, someone in jail. And there are about, you know, 10 or so items, you know, and they are known items that contribute to long-term mental health challenges. So what we want to aim for is to ensure that protective factors around the child outweigh the risk factors. That is how we prevent mental illness as much as we can. Where we build protective factors around the child. Protective factors include things like parents that are supportive, that are a healthy, conducive home environment, communication, you know, checking in with the child regularly, protecting the child from certain adverse experiences. These are protective factors. And once it can outweigh the risk factors, the child should be fine. But once the risk factors outweigh the protective factors, the likelihood of a mental health problem becomes very, very likely, very increased, sorry. The impact, like I said earlier on, it will have impact on academic performance, social relationships, their well-being, physical health, opportunities, and poverty. There are certain red flags before we speak about the disorders, some disorders specifically. What will a child or adolescent demonstrate or present with that should make you wonder that, okay, could this be a mental health thing I should take a look at? Changes in mood or behavior. A child you've been taking care of and changes, or parents bring a child and they say, there's a change. The behavior has changed from what we're used to. History of deliberate self-harm. And this is not suicide. Deliberate self-harm is different from suicidal behavior. Deliberate self-harm are what you see in children and adolescents that are cutting. They're doing it a lot now in Nigeria. They're cutting themselves, razor blades and cutting their bodies, making their, I've had children, they'll take matches and burn themselves. They are literally scarring themselves. And it's not with the intention of dying. It is described by them as a way of relieving the psychological pain and distress that they're feeling. So we must watch out for it. We have the adolescent coming with long sleeves every time. Do a proper examination. Roll up your sleeves. Let's check the arms. Cutting is increasing. It didn't used to be as much, but yes, globalization, these are some of the effects. Psychotic symptoms, hearing things, seeing things that are not there. I think that's pretty much clear. Mood fluctuation, where the mood is unstable, either they're having manic symptoms or depressed symptoms, or it's up and down, and it's different from how the person used to be. Severe aggression, mood lability, where the mood is labile and it's not settled. Deterioration in functioning. A child that ordinarily would organize themselves, go to school, have their classes, they're doing all the things they need to do, suddenly stops, doing that, locks themselves in, doesn't want to see anyone. There's something going on. Withdrawal from social activities, decreased interest in activities, changes in appetite, or sleep patterns, either excessively or it's reduced, difficulty concentrating or paying attention. These, I think, would be a safe, combination of red flags that you can look out for any of them. So I want us to bear in mind that mental health is a continuum. It's not like, oh, you have mental health and you have mental sickness. No, it's usually a continuum. You are healthy, and they could have mild mental distress. Oh, this is too much. I'm overwhelmed, I'm stressed. It's not a mental illness yet. Just that the person is distressed, okay? And it's a good time to intervene and provide support, counsel, and that may be all. Then you have moderate situations where there are mental health problems, I'm not sleeping. I'm getting very irritable, a bit more aggressive, but it's not meeting criteria for a diagnosable condition. So we may not diagnose it, but there's a mental health problem going on. So that as I use the term mental health issues, it's a bit fluid to encompass anything outside of, being healthy, okay? So it is a continuum. It's not an off and on switch. It's something that can continue to be improved upon, or that can gradually become worse, depending on what the child or adolescent is exposed to in the course of their life. So irrespective of how they show up, assessment and diagnosis will be key. And as a clinician, you can do a comprehensive assessment, and at some point in time, inquiring about their mental well-being. How do you feel? Any suicidal thoughts? Any trauma? Any abuse? The common things, as they say, occur commonly. Let's just check in. Clinical interviews and observe the behavior. Psychological assessment using some of the screening tools, some of which I'm going to mention in a bit, may be useful. Laboratory tests and medical evaluations oftentimes are useful to rule out comorbidities. For example, in my clinic, when I see children and adolescents, I routinely do a T3, T4, TSH, just to check, could this be a thyroid thing going on? This child is behaving, let's just take out the thyroid and be sure that everything, when I say take out, not physically take out, I mean rule it out, that there is no problem in that regard. So effective screening can be a very useful tool that you can begin to imbibe. I think that's a very low-hanging fruit you can imbibe into your clinical practice. It's not diagnostic, but it helps you to flag possible cases, and a referral for a diagnostic interview may then be needed if you are suspecting something. When we talk about screening, I'm sure you're all waiting for me to talk about diagnostic disorder. I'm going to talk about them, but I want you to realize that it's beyond it. It's about all these other things before you then, oh, could it be this, could it be that? And at times you don't know what it is. You just know that something's amiss. We need to refer, okay? So you can screen using some general primary screening tools, such as the Pediatric Symptom Checklist 17 or the SDQ, the Strengths and Difficulty Questionnaire. It just helps you flag, that, okay, some areas there seems to be something going on. Let's get someone else to take a look at. And there are other ones that are a bit more specific. The ones I've started, the Patient Health Questionnaire, PHQ, for adolescents, A is for adolescents, is a very useful screening tool to assess depression symptoms in adolescents. Honors rating scales, which will be given for the teachers and the parents, can help to rule out things like ADHD, okay? So that a patient is endorsing a lot of symptoms that are suggestive, then maybe they should get a formal, assessment and review by a mental health expert and a few other screening tools. But from my end, I'll probably endorse the PHQ-9. It's very user-friendly, I think, and maybe the pediatric symptom checklist, just to check if there's any, because the way the questions are phrased, you may not be able to phrase it that way. Indeed, I also, even after doing clinical interview, at times I just use a screening tool to just be sure that the questions are asked exactly in the right way that may help stimulate the correct answers from the patient, or to also ensure that you don't forget certain questions that you should ask, because, hey, how many things do you need to remember by, by yourself when you can go through a screening tool? WHO has also developed a tool known as the MHGAP Intervention Guide. It's a very useful tool that a portion of it focuses on child and adolescent mental health and behavioral disorders, which some of you may find useful. For some, it may seem a bit bogus, but I think it has a very nice algorithm that you can use to just ask for this. If this is not there, ask for that and all that. And if there are ways of maybe adapting it or simplifying it in a way that you find useful for yourself, there's a section on child and adolescent mental and behavioral disorders in this tool that goes through several things, and these are portions of the guide that I just highlighted on this slide, and the different presentations. I'm sorry if the print is too small. It's small from my end to read now, but it's available online, and it's I think it's freely downloadable, so you can even just crop out this portion. I hope you can still hear me. Is my internet good? Am I still being heard? Hello?
Yes,
Loud and
we
clear.
can.
I can hear you.
All right, because it was just rolling. I was wondering. Okay, so it may be something to take a look at. I just thought it was nice to highlight that. And when you think about treatment and management in the interim, what do I do? What do I do? Well, usually what we try to do, we're thinking biopsychosocial. We may give medications, that's biological. We may offer psychotherapy. We may look at the social life of the patients and their families and see what we can do to adapt, to assist them. Like I said, it's not to make you a psychiatrist, but you may be working somewhere that, a mental health expert is far away, or so what are the little things you can do? Meet with the family, some family therapy, just counseling them. It's basic. It's not like psychotherapy, I know, but it's better than nothing. Let them understand that what they're doing is affecting their child. I have a almost 17-year-old young man, and the parents fight in front of him, and he's generally zoned out on them. He's depressed. He doesn't want to talk to anyone in the house. They're talking down at him, even though he's that old. He has a sibling on the spectrum. It's so much for this young child. I had to tell the parents, you people need to just stop and think about this person, and let's put him in the center and work in a way that enabling, creates an enabling space for him. At times, the parents don't know better. And am I running out of time? Can I get a prompt? Am I good?
Go ahead. Go ahead.
Okay. Okay, I'm going to try and move faster, but if I can know when I have like 5 more minutes, that will help to really know what I should. Okay. Yeah, at times you need to look at their diet, at times you need to encourage exercise, and little things could go a long way. Essentially, we want to adopt a good approach that is offering primary intervention, secondary intervention when they come to you, and tertiary when you refer them to mental health professionals. Common disorders that you may see in your clinic: ADHD, attention deficit hyperactivity disorder. They're inattentive or hyperactive or impulsive. So you either have inattention or hyperactivity and impulsivity. Those are the two broad types, and then at times you can have a mixture. And oftentimes we assess them with these questionnaires. Behavior management, medication. Medication is the gold standard, methylphenidates, which we often prescribe. I think the pediatric neurologists also at times do offer medication. The meds are very scarce currently in Nigeria, although fresh batch just came in. So I don't know how long that will last for. Autism spectrum disorder, oftentimes these are children that they've had these symptoms from early in childhood. They present with communication, social communication difficulty, along with restrictive and repetitive patterns of behavior, and these two rubrics of disorders can manifest in so many different ways. Social communication difficulties could be they don't respond to their name, they don't make eye contact, they cannot communicate in a back and forth manner, they're socially awkward, they can be inappropriate in the social, they just, jump into conversations or blurt out things that ordinarily most people wouldn't, or they have restricted interests or preferences, you may be dealing with autism spectrum disorder. Most times the intervention is behavioral, and it has to be intensive, and it has to be early. In a few cases, we may need to add medications, because at times they then have meltdowns from different situations, that need to be contained with some of the medications when they get very disturbed or disruptive. However, it's mainly collaborative care. Oppositional defiant disorder, some will argue this is not really a disorder, it's really just poor parenting. The parents have just learned to not keep boundaries, and this child has grown up to be badly behaved, they're angry, they're irritable, they're rude to adults, they don't keep to rules. That may be something that may show up in your clinic. Depression, I suspect that you're all familiar with this, the commonest, one of the common ones, depression and anxiety, persistent sadness that is more than regular sadness. And it's not sadness alone, you then have loss of interest in previously enjoyed activities, like in the case of Chichi, the case scenario I painted, and changes in appetite or sleep. I must point out that children at times may not have the language. Remember, we are being developmental to say, oh, my mood is low. They may not. You may just find out they're having a lot of physical complaints. My tummy is hurting me. I don't want to go to school. I'm having a headache. My neck. It may be depression, but we need to rule out other things understandably and check if there are things that are difficult going on in the environment beyond these obvious things that, okay, maybe it's just a fever or something, or the child has, something, maybe a bug in their tummy, it may be depression. Younger children tend to somatize a lot rather than talk about their mood and stuff like that. We give antidepressants. For children, it's fluoxetine, that's our drug of choice. Sexually, maybe the older adolescents, okay? Anxiety disorders, excessive fear, worry, and anxiety. It could be social anxiety. It could be regular phobias. With age, as they grow older, you can have a few more, kinds of anxieties that have happened in late adolescence, things like agoraphobia or OCD. Those ones happen in older adolescents. Conversion disorder. This is a situation where a patient will convert a psychological experience that is distressing into neurological symptoms. Suddenly, I can't see. They become blind, or it looks like they can't see. Or rather, they can't see because they have converted that experience, that psychology, to this neurological deficit, or, oh, it's hard for me to swallow, or I'm having seizures, we need to check. And the pediatrician has ruled out everything. It's not in keeping with the standard presentation of this disorder. It may be a conversion disorder. And seizures, pseudo seizures, oftentimes may fall in this category also. Malingering, Munchausen syndrome, that's factitious disorder imposed by another. That's where the caregiver is imposing an illness on a child or on a child that is not there. Saying, oh, he's so sick, he can't even eat anything. The child comes, the child can eat. Oh, he's so sick, he's been running the fever, and he found that it's not that bad. What exactly is going on? There may be some benefits that the parent is having by infanticizing that, adolescent. Oftentimes that may be happening when they're making their problem look worse than it actually is. I see some messages in the chat. I'm wondering whether it's for me. Okay. For some reason, I can't read the chat. Okay, questions. All right, thank you for the question.
There are questions,
yes,
we'll read them after.
Okay,
yes.
Okay, all right. Like I said, it's not exhaustive, but these are a few things. Organic brain syndrome, we see that a lot, especially in the teaching hospital setting, or a child is experiencing delirium. That's very, linked to an organic illness, and oftentimes the symptoms are worse later in the day, in the later part of the day. And another thing that helps us to see clearly, they may have visual hallucinations. When we have visual hallucinations and you're having agitated behavior, oftentimes with a sundowning phenomenon, more worsening in the evenings, it may be a delirium, related to the underlying cause. Oftentimes we'll give low-dose antipsychotics to just tie the person and control the behavior, while we encourage pediatricians to address the main condition, and different medical conditions could present to this. Pain management, we don't see this often. We don't see this in we don't get called to do this often, but I do know that in many other parts of the world, at times you're having a patient, the pain is difficult to control. At times they'll invite mental health team to come and take a look, and maybe a clinical psychologist to help in seeing what we can do to help manage the pain. Suicidality, that's pretty straightforward. I will stop there. I did see the eating disorder, and yes, it is one of those things that could require a multidisciplinary approach, and I'm happy to talk a bit about that. So moving forward, we need to move beyond the silos. We need to move beyond working, we are just pediatricians, we are just child psychiatrists. No, there has to be that intentional, collaboration. And, this article in PubMed, essentially speaks to that. The service delivery in child psychiatry was not just about the fact that we don't have enough experts. I mean, this was in a pediatric setting, but really we're not collaborating enough. That's why the service delivery of child psychiatry for in childcare services was being deficient. So we need to be proactive, not reactive. Let's intentionally see how to embed, a process, put a process in place. Some general principles: plan to collaborate already, collaborating over case management, collaborating over planning, collaborating over putting together treatment plans, multidisciplinary teams sitting over the care of a patient. I know with Professor Lesh, we used to do that quite a bit over a couple of years, where we would have MDTs over cases that were either from us to them or from them to us, that we saw that there were things we needed to discuss and think around together. That's in a teaching hospital. And hey, it can happen in private also, once you have that plan in place. And it can be virtual. Thank heavens we have this virtual option. So calling someone out, from a long distance may not be sustainable or maybe inconvenient, but scheduling when can we have a meeting to just discuss this case? That may be an option. That may be an innovation to look at. Conducting a comprehensive assessment, bearing in mind the emotional and psychological needs of the patient. I think that cannot be overemphasized. Relying on using evidence-based treatments, that are tailored to the child's specific needs will be important. So it's not just because we think this is what should work. What's the best evidence? And let's try to work with. I know we work in an environment where at times the best evidence is not available, I know. So then what's the next best evidence, okay, that we can deploy? Family-centered care. We need to carry the family and allow the family realize that they have a role to play. I just have maybe 2-3 more slides and I'll be rounding up. Let's think about building cultural competence that will help us be culturally sensitive to the backgrounds and values of the child and the family. You may have a child and family that they are, say, very religious, or they're very, I mean, recently I had a family come to me, they're international, they're, you know, Caucasian. I will not talk to them the way I talk to our Nigerian. I need to be mindful of how, you know, and our Nigerian people, I will not be treating them like Rainbow people, because understand they may need a bit more explanation. They may not be as psychologically aware. So just be mindful of the patients and their various needs. And we keep trying to improve upon that, okay? Monitoring and follow-up, prevention and early intervention. So it's key that we offer empathy in all our interactions. Remember empathy. Empathy is putting yourself in the patient's shoes. How will this person feel? Just stop a minute and think. How will these parents feel? At times we get it, at times we don't. I understand that. But as long as we keep trying, we can only get better. Okay? We must learn to also listen to the child. And we listen with our ears, and we also listen with our eyes. I know eyes are foreseen, but there are things that at times are not said that you can see. You can see when a child cowers, you know, in fear. You can see when a child, you know, gives the parent side eye that, if I talk now, you can see things that are not said. As clinicians, it's important to be psychologically aware of the patient, of your own self, and of unseen factors. At times, even you may be a certain way in the consulting room that shuts down the patient's willingness to communicate with you. We need to be mindful about that. Are you a clinician that's potentially coercive in your approach, or potentially high-handed in the way you are talking to you? You're going to shut them down. So it's just becoming more self-aware also in the way you're interacting with your patients to get the best out of them, and be willing to refer when necessary. Identify the useful pathway that you can deploy to mental health care in your setting. When I say pathway, you may be in private. What are the options you have in your setting? What resources do you have that you can, if you do have mental health needs in the clinic, that you can reach out for? Are there teams? Indeed, you can even have peer supervision where colleagues can kind of like band together. I mean, this really is a kind of a peer group, even though you are different levels and seniority and all that. But having a session like this where you talk about tricky cases, I'm sure you may be doing that for pediatrics, bring in the mental health and let's see, you know, and then everyone chips in and, okay, have you thought about it? And then you can go back and give the patient, you know, the best. And I cannot overemphasize the importance of a trauma-informed care, where you are informed of the effects of trauma and the fact that it can color everything. And because of that, you're willing to try and see how to help them to get help. All right, the pathway to care, you know, let's have a care referral pathways and utilize it. So children and adolescents are an important population group globally and locally, as you can see, and they do experience significant burden of mental health problems. And because of that, they require our attention. Comorbidity with physical illnesses is also not unusual. Indeed, it may well be more usual than we can imagine. As pediatricians, you play very significant roles in detection, in management, in referral and follow-up of child and adolescent mental health related cases that require support. Screening can assist you a lot. Please embrace it. Even if it's just one tool you begin to embed into your practice, it can really help you to even ask questions like, well, you didn't even know how to ask in the first place. Collaborative and integrated care is necessary for good child and adolescent mental health care of pediatric patients. So on a final note, I'll just say that really many things can wait, but the child cannot. Now is the time. His blood is being formed, his bones are being made, his mind is being developed. To him, we cannot say tomorrow. His name is today. That's a poem written by a Chilean author who advocated a lot for women, children, and the poor. So I thought it's a very timely way of phrasing all of this. He cannot wait for tomorrow. His name is today. Thank you for your attention. My references. Thank you very much. I'll be happy to take questions.
Thank you very much, Dr. Oshodi, for that excellent presentation. And I didn't expect anything less than what you had given us. Thank you very much. You just that I'm not a psychiatrist, but you said we're not going to make us psychiatrists, but I don't know whether some of my colleagues here may be thinking of, porting to psychiatry. Well done. Thank you very much.
Thank you.
You speak so easily about these conditions that a lot of us worry a lot about. Thank you very much. I'm not going to make an attempt to summarize what you are giving us because you've really, really loaded us. So we'll go on to questions and answers now. I see Dr. Nifade's hand is up, even though she had put a question in the chat box, but I think it's better for her to verbalize her question herself. Over to you, Ma.
Oh, my hand is not up. I'm clapping for her. It was a clap. I must have clicked
Oh, okay, it was a clap. Okay, it was a clap. Thank you very much.
Thank you, Ma. Thank you very much, Ma. Good to see you.
Thank you very much. So while I'm waiting for people to signify if they have questions, I'll just read out Dr. Nifade's question. So I just wondered if children with problems like OD, anorexia nervosa, ARFID, and self-harm turn up commonly in our ED or in our clinics. Is there a crisis team on hand to support physical health care practitioners? Also, with regards to manpower difficulties, will training other supportive mental health practitioners, e.g. mental health nurses, psychologists, and so on, be helpful? So, please note the questions. I'll take on a few more so that you can answer together. Dr. Fakunle also has a question here. He says that is universal health coverage is not universal if mental health is not covered. I think that was just a comment. Then he had two questions. What is the place of mental health in primary health care? How can we make it more visible given the poor state of the majority of our PHCs? The second question actually has three questions. Second question is, which of the psychosocial screening tool will be more useful and relevant to use as part of a school health program? Can you share these tools with us? Then his third question is gender dysphoria. Transgenderism. Dr. Ifade is laughing because it's something that we are not very used to. I know she's used to it
Can I take some of them in batches so I don't...
Okay, should I just stop now?
Yes,
let me
please,
stop now. I'll come back to this gender dysphoria later because
I think we should stop at gender dysphoria. We'll come and fix it.
Okay, so go ahead and answer the first three questions.
Thank you, sirs and ma'ams, for your interest and for the questions. Eating disorders are, we used to say that they are not common in this part of the world, that it's a Western thing. But like I said, the effect of globalization, we're seeing it more. However, oftentimes the parents are, I may be wrong, but oftentimes they're highly educated, they are empowered, they may rather prefer to see a pediatrician, and they don't even know what's going on. And when they do know, they're not keen on seeing it. I've had patients with anorexia nervosa before, and the biological parameters were everywhere. This child was not cooperating. We had to think about placing on antipsychotics, which are some of the medications that can help. But we needed to collaborate with a pediatrician. And for some reason, the parents fell through the cracks because they weren't very happy seeing, a psychiatrist at all. And they had been shopping around. It does exist. That's my short answer. But I don't think they are coming to us. they're either going elsewhere. They eventually took this particular child outside the country to some camp to address the problem, and I don't know what the outcomes were. So it is happening. They're learning how to restrict their diets and overly exercise. In the course of my, I became a psychiatrist in 2007. I've maybe seen 2 eating disorder. So it's not common, but it is present, and maybe it's not, I suspect it's not picked enough. That's it. So training other supportive mental health practitioners to help with manpower difficulty. Oh yes, we do try that, but I'll let you know that it's still not enough. I remember when we started doing a lot of public health work in Bakoto, which is the outpost of Luth, and we didn't have doctors again. We trained a psychiatric nurse, and she's offering the services there. But this current JAPA problem knows no gender, no creed, no specialty. It's everybody. So we are faced with that, and I'm sure that you also, are faced with the same. Yeah, so we'll keep the training, we'll keep on doing the training, creating awareness like this, and everyone just being able to detect mental health problems. The role of mental health in primary care, yes, it has a very significant role. There is no health without mental health. That's a mantra that we like to say. You cannot give any health without thinking of mental health. And people that have tried to do that without considering mental health have realized later that there actually is no health without mental health. And we as mental health, we don't chase patients around or anyone, but at times it will show up. And so we need to create more visibility in primary healthcare. There have been efforts in Lagos State in particular to offer mental health services at the primary healthcare centers, but some of us may have observed the primary healthcare system is pretty much not the same as what it used to be, and the services are not as robust as they used to be. So I think it's still very deficient in that regard, but we'll keep the conversation going and the training going on. Psychosocial screening tool, I think it will depend on the age. And if you're thinking general screening tool, I think SDQ will be the one, because that's a strengths and difficulty questionnaire. It has different age ranges, and I think it starts from 4 and it goes well up to 17. So you can have the parents and the teachers score it and take it, and then you rate it, and you can flag some areas that you may want to pay attention. But if you're thinking something for depression, I think the PHQ, like I mentioned, would be a good one. Gender dysphoria. Gender dysphoria is in our country. It's here. It's here, except we want to play the ostrich. I remember there was a point in time I had about 4 or 5 patients that I was seeing that had gender dysphoria at the same time, wanting, I'm a girl, I'm in the wrong body, I think I belong to another body, I'm a girl, I hate, and I think they were all female. They were all female, if I remember properly. So they're self-harming, they want to transit, and I don't offer transition services, so I help them what I offer. I help them take care of their depression, their anxiety, and secretly hope that maybe it's something that will pass. And yes, so it is here. Transgenderism in pediatric population, we have them in this environment. That's what I would say. So what would I suggest? I would suggest that we try to not be prescriptive or coercive. It's not our job as a clinician is not to be a moral, what's the word now? Help me, a moral whatever. It's to offer them care, health care. Because at times we mix it. We want to lecture and all of that. And I say that because I know half of the room is probably very cultural and traditional about our views about that. And I also have my very traditional views, but our role is to be a clinician, a doctor that is willing to care for a patient that is in need and is in front of you. And once we can separate that, we can focus on that, and then leave the other issues that you can let them know I'm not competent in handling this one, but I'll help you with what I'm competent with handling. Let me stop there. Dr. Fajolu, the other hands up. Thank you.
Yes, thank you very much, Professor Grange. one of our elders, revered elders, is been,
Good evening, ma.
our electronic hand has been up for a while. Sorry, ma, for allowing you to keep your hand up
No
for such a long time.
Good evening, Prof.
Please,
Good
ma,
evening,
Good
ma.
I'm
evening.
going
No
to
problem. You and that was
allow you to
excellent.
Yes, ma.
come on, ma.
Yes, that was really excellent, you and I.
Thank
I
you.
wished we had been able to produce many more people like you earlier on. We will be the stage at which we are now would have been different. My question and comment is this: to what extent do you think that the current curriculum for medical students and nurses is making them more aware of the importance of adolescent health? Adolescent health, to me, is something that lives with us, all of us. But unless there is an awareness, you cannot actually help them. There are so many patients that will not come to you, because the people around them are not aware that they are struggling, that they have problems. So somehow the training of the general doctors, everybody needs to inculcate in us some level of awareness of the importance of mental health and how to suspect it when you are around the adolescents. One of the other problems is that if you don't suspect it, they go on to taking drugs, and they may become junkies, from just simple mental health problems. I don't know for how many times you have seen those cases before, but it's very important. And so I believe that there is need for multidisciplinary mentorship, both before qualification and after qualification. So I'll leave it at that. But your presentation was really fantastic, awesome.
Thank you very much.
Mhm.
Thank you, ma. Thank you, ma.
Thank you, ma, for that. I'll ask the two hands up and we'll allow them to ask their questions. And we have, I think, 2 or 3 more questions in the chat box, and that will be it because we are really running behind schedule of the time that we had planned for this. But I expected this because this is a topic that usually will generate a lot of questions. So I have Emmanuel and somebody called Dell. I'm not sure if that's your name or the name of your computer. So Emmanuel, please. I don't know who that is. You have
Yes,
the
thank
floor.
you. All right. Thank you, Ma. Thank you, Prof, for the wonderful, lucid, and elaborate presentation. And it was a very nice one. My name is Dr. Emmanuel Onweluzo. I'm a consultant pediatrician. And it was quite interesting listening to you. I want to ask, to what extent should a pediatrician evaluate and treat a child with or an adolescent with a possible mental ill challenge before referring to a mental health expert? That's one. And then I want to ask again, are there specific mental health screening tools for different mental illnesses that are recommended in children and adolescents that can be used by a pediatrician to evaluate these children properly or adolescents properly before arriving at a possible diagnosis? Those are my 2 questions. Thank you for the presentation.
Thank you, Dr.
Thank you.
Wilson.
And they just can the second person ask his question before you go
Yes.
ahead to answer? Please go ahead. And introduce yourself, please.
You're muted.
Dale, you are muted.
We can't hear you.
Okay, can you hear me?
Okay, yes, we can now. Go ahead.
All right, good afternoon, everyone. So, first of all, my name is Salman Shata, speaking with you from Republic of Seychelles. So, who is currently on the national assignment to serve as a psychiatric mental health nurse here in Seychelles. So, what I want to say, I just want to like share something or contribute something which will be also beneficial to my country, Nigeria. So actually, since I came to Seychelles, I've been working with their teams of mental health or psychiatric mental health. And despite that, the country is small and they lack a lot of resources, especially the manpower or the mental health practitioners. But the way they work actually really impressed me. So I say it's good time for me to share this at this point so that we can be able to learn some things from them, and maybe when we put it in place in our country, it might really assist or help us. So I know when I came to Seychelles, I think they have not more than 6 consultant psychiatrists and not more than 9 psychiatric nurses. So, but the way they carry with their mental health services is quite impressive because as I told you, there's a program which really covers almost every aspect of mental health, which they call community mental health. And this community mental health, they tend to go out, so have a surveillance, look at people, manage them at home, and give them a lot of things which has really helped them and is really helping them. So I think it's high time in my country we start to think of doing something like this. Despite the large number we have in the country, but I think with the little resources we have, this can go away helping the country and at least assist in mental health care services. So thank you. This is the only thing I would like to say. Thank you so much.
Thank you very
Thank
much.
you.
Thank you very much for that contribution. Yewande, over to you, to the questions that have
Okay,
been
thank
asked
you. Thank you
by
very much for
Emmanuel.
the comments and the contribution. Professor Grange, thank you very much, Ma. I absolutely agree with you that if our curriculum can be robustly built up around the issues of child and adolescent health and mental health in particular, can also help bridge the gap. I would say that in the College of Medicine over the last maybe, and Dr. Fadjo, you may correct me, maybe about 5 to 10 years, there has been an intentional mental health. At least since I started working, we've had a child psych lecture that the students go through in pediatrics currently, which I'm not sure it was as visible as it is now. If I still give the lecture to the students yesterday, just to create an awareness to them that this is important. Maybe the piece that I hear Prof speak about that maybe we need to elaborate a bit more is just understanding the risks that adolescents are at just by being an adolescent. Like I mentioned, the way the brain has developed, the executive functioning bit, which helps them to know not to do certain things at certain times, is lagging behind the reward center. And so they're very impulsive, they're risk takers, they will abuse substances. Their brain is wired to look for substances to abuse because they're curious. And when we understand that, we can begin to guide adolescents, our patients, and even our children to know that your brain is wired for excitement and risk. Let's give you a positive excitement and risk to explore. And that way we can help keep them away from the risk of substances. Substance abuse and mental and depression and whatever have been closely linked. I saw a patient once, medical student, 3rd year, had been flown out of this country, had to be brought back because he was abusing substances. By the time we explored, this young man had become depressed from secondary school and nobody knew. And he started taking substances to help him feel better. So he's ended up with 2 mental health challenges, the depression and now addiction to substances. So if we can prevent the onset of these, or at least help them manage it, it will go a long way. So thank you, Mark, for that. To what extent do we evaluate and treat? I think this was from Dr. Wendelzo, I think. I think you can evaluate and support mild cases. For example, when we talk about depression, we have mild, moderate, and severe. At times, mild depression, just a bit of counseling and supportive care may be enough, you know, and encouraging them to exercise. I think at the level of a pediatrician, you can easily do that. In some cases, and I know that outside this country, and maybe Dr. Nifade may want to correct me if I'm wrong, but I think like the NICE guidelines may actually permit pediatricians to even prescribe some antidepressants. I don't know whether in the UK, but I do know there's some guidelines outside this country that does permit. But in Nigeria, we're not talking about that. Ma'am, am I correct, ma?
You should revert to Bumi Lawson to answer that question. No is my experience.
Okay.
Bumi Lawson can
maybe
answer that question.
Okay, Dr. Lawson, ma. Well, I'm just saying that it's possible that there are some places that pediatricians do prescribe, but I think familiarization with the medication side effects, and what to do, and knowing where to just kind of like stop and refer. So maybe something like depression, yes, it can be managed.
I think there are different care pathways. If you took something like ASD, ADHD, there is a multi-agency team that will deal with that in younger children. And then every child above 5, for instance, will be seen by the psychiatrist. So we have to develop our own care pathway that suits our society. And that's what we should do.
Yes.
That's what I
made that point. You're correct. I made the point to just say my answer may sound absolute, but I do know that in certain settings, there's accommodation to do a few other things. But it's that, I like what you put, we don't have that framework that says, okay, up to this point, and it has to be collaborative in designing that. So specific tools, I'll still stick with the PHQ and the strengths and difficulties questionnaires. To the final comment from Doctor from Seychelles, I think it's an amazing thing what you've described, and I do know a few countries that have similar, but do not forget that we're a population that is about 200 million, and in this country we have just barely 200 psychiatrists. So the mental health services, I'm expected to see over 1 million people. It's not going to work. We try to step down. We are training. That's why we have these kind of conversations to underscore the bit that everybody needs to be concerned about mental health. And even just at the family level, being aware and being better with the children may prevent some of the things that we end up seeing in our clinics. And it's these kind of conversations that will make us more aware, and the services may be better improved, better integrated, to give the best results. Thank you very much.
Okay. Thank you very much, Yewande. So I have 3 more questions on the chat. It's been a long day, but we'll soon be done. Dr. Wenike Briggs has a question on the impact of social media on child and adolescent mental health, and if you could share any experience. Then Dr. YJ also had a question on the screening tool that could be used in outpatient clinic setting. I don't know if the answers if given will suffice, and how often should this be used, and should the screening tool be used on all adolescents? That would be so. That's from her, and then the final question here is from Dr. Eruri. In a resource-limited environment where there is no pediatric psychiatrist, I wonder how many we have here one day, because I was thinking as we were talking that we are privileged in Luz to have you around. I don't know how many other centers have pediatric psychiatrists, and that most of these cases are seen. When a referral is decided, the majority of these patients refuse, reasons being that the distance of the available because of the distance of the available pediatric psychiatrists, what can be done?
Okay. Thank you very much. I'm going to just attempt to answer the question, because I think there may be lots of angles to it I may not be able to touch. The first one concerning impact of social media on child and adolescent mental health. The impact is, I'll say the impact is much more than we can imagine. It's much more than we can imagine. For starters, you have people with young children, they're using devices to babysit their children. That in itself is a problem, because they don't want the child to make problem. They just give the child the phone. The child is pressing away on the phone. The child learns to just It's feeding the dopamine supply in the brain. And dopamine is the addiction, neurotransmitter. And the child becomes hooked, period. And then you start having all sorts of other things coming up. And that is not even mentioning the things they're learning, the content that they're feeding on, and the effects of that. I had a patient once brought to me, maybe a 9-10-year-old child who is usually picked from school, taken home, supposed to be doing lesson, and gets expelled from school because she goes to the toilet and presses the breast of her classmates. And they expel her. And they find out that this child, when she's supposed to be doing homework, she's browsing porn sites. She has browsed over 300 porn sites by the time the mother is discovering, and has learned what the mother has never taught her. So just the rest is left to your mind. And these are not fictitious tales. These are real life experiences. I think pediatricians may need to put out a statement about this. I hear in Australia, there's a ban now on certain things about social media for children below a certain age. Maybe it's a conversation, I don't know, that we need to think about, because it's a disaster waiting to happen. I've spoken about cutting and all of that. They're picking it up on there. There are sites that are teaching the children how to self-harm, how to commit suicide. And these are still, the list goes on and on and on. I would say we need to maybe have some guidelines about what we want parents to know about social media tools. And as I say we, I'm including myself as a mental health expert also. Maybe we've been too quiet about it, and say people should have bound. If your child must have a device, we recommend this age. If they must have one, we provide these guidelines, they should have it only on this time. They should have it. So yes, the answer is yes. The impact is a lot, and we need to think about preferring some, because we're stuck with social media. It's not going anywhere. Dr. Waje, thank you very much for your question. I would agree that a screening tool being embedded into outpatient clinic setting may be a good idea. And I think private setting may be a good place to have it, and maybe something that you just have all patients fill, and you then have a standard scoring system of the tools that you can then identify those that are scoring above, and then, so that way you may not necessarily go through mental health assessment for all patients, except those that are flagged based on the scoring tools. I know there are some pediatric tools that I mentioned on that. I'm not familiar with them, I must say. It's in the course of this preparation of this lecture that I found them being mentioned, but the child behavior checklist, I heard that come up quite a lot, but unfortunately it's very lengthy. It's very long. So that may not be the right fit for an outpatient clinic. But if you think it can, maybe it's something you mail to them, they fill out before coming. So I'll say it's a good idea to maybe have that. Then you can use that to flag those that require. So it's like a baseline screening, and then you offer some intervention for those that are suggestive based on their scores to inquire a bit further. The last question has to do with not having enough child psychiatrists because of and the distance and all of that. Dr. Fadru, I sincerely don't have the answer to that question. It's just they're not enough. And maybe collaborating online assessments, we may need to innovate solutions. In Nigeria currently, we're less than 10 that are qualified subspecialists in child and adolescent psychiatry, for starters. But we do have other colleagues that have been trained in child mental health, generally nurses and all of that, are a bit more aware. So maybe put together, maybe we're 50. It's still grossly inadequate. So what are the innovative strategies we can have? Once a quarter, grand rounds to discuss difficult cases, maybe that's online, maybe something like that, maybe a way to go, and you think about paying people for their time, because at times we inadvertently cheat ourselves, and then people become discouraged, they don't want to come. And I'm just being as, direct about it as possible, because that's what will make people fall out of that kind of arena, because it's time out of no time. But if you have that kind of thing in place, it may, maybe. I have patients reaching out from the UK because they have waiting lists up to 2026 that want to bring their child from the UK to Nigeria to see a child psychiatrist. So we're not alone. even abroad, they're facing problems because the waiting lists are horrible, they're unimaginable. So we must be creative. Thank you very much.
Thank you very much, Dr. Oshodi. It's 5:34, and you must not agree with me that it has been a very, very interesting discussion today with our erudite speaker, Dr. Yewande Oshodi, talking to us about child and adolescent mental health. So we all know that everybody has a part to play in this. And I say a very big thank you to you for coming on. I'm going to hand over the mic to Dr. Eletu to conclude. Thank you very much, Yewande.
Yeah, thank you very much. Yewande, I didn't expect anything less. As you are aware, I started off as a psychiatrist and I ran to pediatrics. So I'm not one of the 50 you are counting. Well, you've done an excellent job. We're quite happy with your presentation. And we want to thank you especially again, even though the notice was short, but you did show us why you are a consultant psychiatrist. So thank you on behalf of the Guild. I will hand over to Dr. Mobolaji Lawal for his remarks before we close. Over to you, sir.
Well, thank you. Yeah, so it's a long afternoon, but without any doubt, a time very well spent. I want to thank again our speaker, Dr. Oshodi, for very excellent presentation. The content is very detailed. I'm sure we'll have the presentation sent to us on our platform, and the presentation really is superb. When you listen to psychiatrists, you just want to continue listening to them. So thank you very much indeed. We are highly honored to have you here with us, and to all the insightful comments and questions. The participation has been top level, and particularly I want to thank Professor Grange, our mentor and chief encourager, for always making time to be here all the way from abroad, and all the other people who joined us from all over the other continents, from the UK and the Americas. We also had several distinguished pediatricians who joined this meeting. So a testimony to the importance of the session. So it's been a very useful afternoon. I have learned a lot, and I'm going to study the slides. When I receive them, I'm going to spend quite some time to study them because there's a lot in there. And I'm sure many other people will find this so useful. Thank you, Dr. Fajolu, for very ably managing this session as usual. And Dr. Eletu for your indefatigable efforts in this regard. So on that note, I wish everyone compliments of the season. I hope you have a very enjoyable holiday season. Thank you all very much. Over to Dr. Eletu or should we declare the meeting closed?
Thank you very much, sir.
Yeah.
It's been a wonderful evening, like you said, and we're looking forward to seeing all of us last Thursday, January 2025. That will be immediately after Bank of Gombe. So we expect that we'll see you in Gombe. And to say a big thank you to all those who joined from outside the country. I think we're really international. So have a wonderful holiday, Merry Christmas, and a Happy New Year. And again, Yewande, thank you very much. God bless.
Thank you, sirs. Thank you. Bye. Bye-bye.
Bye-bye.
Thank you.